So thank you to the organisers for inviting me to speak today. So just a caveat, this is a huge topic, and I'll try to cram as much of it into 25 minutes as I can, but bear with me. So the aims of this session are to talk about the incidence of infection in kidney transplant recipients, sources of infection in our transplant patients, minimisation procedures, and then various different treatment options that we have. So infection in transplant recipients is a leading cause of morbidity and mortality. One North American study has demonstrated that in children and young people who have had a kidney transplant, 48% of those have been admitted to hospital for an infection-related hospitalization by 36 months after their transplant. And actually, anecdotally, I would say that, from my experience, it's probably actually higher than that, particularly in the younger patients as well after transplant. North American data shows that there's been an increase in the infection-related hospitalizations between two different time points, so between 1987 and the year 2000. And that's especially true for patients kind of 6 to 24 months post-transplant, and less true for those in the first 6 months post-transplant. But despite that, we've got data from Australia and New Zealand, from the Dialysis and Transplant Registry there, showing that there's been a reduction in infection-related mortality between two different time points, so 1970 to 1985, and then 2005 to 2015, with an adjusted hazard ratio of 0.16, so a reduction of 84% in admissions, which is quite substantial. The common types of infection that we see in our transplant patients, so it can be recipient-derived, so latent infections, infections that they've been or pathogens that they've been exposed to previously that then lie dormant and can reactivate. And you've got donor-derived infections, so that come with the donor kidney. And then opportunistic infections can either be community-acquired or they can be nosocomial, so hospital-acquired. So this is just a breakdown showing the typical types of infection that we see after transplant. So in the first 4 weeks, it tends to be bacterial-related infections that are related to the transplant surgery or related to, having a urethral catheter in, for example, so increased risk of bacterial UTIs. Then 1 to 6 months post-transplant, you get your opportunistic infections, which might often be at this stage hospital-acquired, and you can get reactivation of latent infections. And then after 6 months, we then see more frequency of community-acquired infections and infections that are associated with chronic graft dysfunction. So in terms of trying to minimize the risk of infections, we obviously do our pre-transplant screening for the recipient and also for the donor. So we touched upon this kind of briefly yesterday. As part of your pre-transplant workup, you obviously want to know what the recipient, how immune they are to various different pathogens, and to make sure they've not been exposed to things like HIV and HTLV1, which is human T lymphotropic virus. So HTLV is a group of retroviruses that replicate similar to HIV, and HTLV1 is the most common one, and we know that in chronic infection with HTLV, about 4% of patients can go on to develop a kind of lymphoma-type illness, and 2% of patients can go on to develop a myelopathy. And that's one that I've never really seen in my career, because we obviously screen for it and it's relatively rare, but just thought I would mention that. We also do screening for TB, so your tuberculin skin testing and baseline chest X-ray, just to look for any evidence of pulmonary TB, obviously, but we would kind of categorize patients depending on their risk for that as well. And you want to monitor their titers of antibodies over time whilst they're on the deceased donor waiting list, or whilst they're being worked up for a living donor transplant, just to see if there's any obvious change over that time point. In terms of the donor status, so there's all the kind of obvious ones that we screen for. Syphilis is also screened for, so the bacteria that causes that is Treponema pallidum. And then we do discretionary testing depending on the kind of individual risk of the donor. So things like malaria screening, toxoplasmosis, and trypanosoma cruzi, which is cause of Chagas disease, which we don't see much of in the UK, fortunately, but much more common in the Americas. And then kind of selective bacterial and fungal screening before we put a kidney into a recipient. So I'll just gloss over kind of pre-transplant immunization because we talked about this yesterday. Fortunately, the routine vaccination schedule in the UK nowadays contains meningitis B vaccination and hepatitis B vaccination. But as Maria mentioned yesterday, we often need to catch up if patients are older, if haven't been vaccinated prior to that, or sorry, after that time point. And then we would do MMR vaccine, which can be brought forward if necessary, and varicella vaccine as well. So all the kind of live vaccines you want to get in before transplant. BCG is optional, but depending on the patient's risk, we still in Glasgow, where I work, we still enforce BCG vaccination at the moment. But it's not an absolute requirement, but we do strongly recommend it. And I'll come back to flu in a second. Any live vaccines need to be given a minimum of 4 weeks before transplant. And if you've had a patient that's had rituximab, then you would want to wait for about 6 months post rituximab to vaccinate them, just because they'll have a blunted immune response to producing antibodies during that time period. In terms of post-transplant immunization, so the various different considerations. So flu vaccine, we would advise on our patients getting yearly, and it should be the inactivated influenza vaccine, which is given as an IM injection rather than the nasal spray, and household contacts should be given the flu vaccine as well. You would consider yearly monitoring of Hep B surface antibody titers, and consider giving boosters, or you should booster them if their levels drop below 10 microunits per mil. Pneumococcal vaccine is very important. It's part of our routine vaccination schedule with Prevnar 13, which is a vaccine that covers for 13 serotypes. But there's a more extended one, Pneumovax 23, which ideally we should be giving to our transplant recipients. And it can be given from 2 years of age onwards. They should have had Prevnar 13 first before they get Pneumovax 23, just to increase the immunogenicity of the response. HPV vaccine is very important, so that's also part of our routine vaccination schedule between 12 to 13 years of age in the UK. And it's the vaccine Gardasil 9, which covers for 9 different serotypes. But transplant patients require 3 doses of HPV rather than just 1. To try and generate the same immune response. And it's possible that, I think with longer term data, that they might actually need more than just 3 doses. The reason this is important is we know that our transplant recipients are a 14-fold increased risk of cervical cancer and an 100-fold increased risk of anal cancer as well. So HPV vaccine protects against those. And I've just put here, is there a role for a mandated COVID-19 vaccination in paediatrics? There's an interesting paper published in Pediatric Nephrology last year that kind of discusses the relative benefits of that, or kind of risk-benefit ratio. And I think the outcome is essentially that because we don't see a huge amount of morbidity and mortality in children and young people with COVID-19 when they're immunosuppressed, is that we probably don't have the evidence to suggest that COVID vaccines should be enforced, but that's certainly very different in the adult population, where they can become quite unwell if they get COVID. So moving on to prophylaxis. So when we think about our infection risk in transplant recipients, it's determined by a balance of epidemiological exposures and the net state of immunosuppression, which will obviously change as the patient moves away from the transplant period, depending on how much, after they've had basiliximab, after they've had high-dose steroids, and as we wean their or allow lower tacrolimus trough levels. In certain circumstances, we'll use universal prophylaxis, so cotrimoxazole would be the main example of that. And I think I would speak for most centres in the UK here, but we use cotrimoxazole for the first 6 months post-transplant, and it covers for pneumocystis jirovecii, and the radiograph on the right-hand side shows the changes that you can get with PCP, pneumonia from Pneumocystis jirovecii. Cotrimoxazole is also beneficial in protecting against uh, uh, some other bacteria as well, like Listeria and Toxoplasmosis, and it does have a benefit of protecting against urinary tract infections with gram-negatives as well. Antifungal prophylaxis is not routine for our renal transplant recipients, but it would be interesting to hear what other centres do across the globe. It's certainly used more commonly in patients who have had like lung transplants, bowel transplants, where immunosuppression is much higher. Then we sometimes use preemptive therapy as well, where we'll monitor the patient very closely and we'll treat at the time of any early detection of a virus or a bacteria. And then there's a hybrid approach as well. So for CMV prophylaxis with valganciclovir, we'll often use that for a defined period, often 3 to 6 months, depending on the patient's individual risk. And this, Chris Callahan just mentioned this yesterday, the Sabtoaid memoir, which can be quite useful when you're taking phone calls for donor kidneys, not just from a cancer point of view, which you mentioned yesterday, but from an infection point of view as well. And the example here is I've used CMV in a donor with acute infection, and then it gives you an indication of the kind of risk of accepting that organ. And that could be quite useful, and that's available on the ODT website. So moving on to treatment, so I'll talk about the big three. So CMV is the first one. CMV is a herpes virus, and if you've had it, then you get IgG positive status, and that implies that you've got latent infection that could potentially reactivate. We've seen from North American data that there's an increasing number of donor positive CMV donors, and then recipients who are CMV negative, which increases the risk of potentially having primary CMV if you're CMV naive at the time of transplant. And there's a lot of practice variation in terms of management. And this has been demonstrated in a French study, but one of my colleagues who's just disappeared, but she has sent out a questionnaire to lots of the French centres, and there was a lot of difference in terms of how long valganciclovir was used for example, for prophylaxis and treatment, and when it was initiated, things like that. In terms of managing asymptomatic viremia with CMV, so there are BTS guidelines that give advice on this. So the suggestion would be to reduce MMF or azathioprine, an antiproliferative agent, once you've got asymptomatic viremia. The cutoff for that is not particularly well defined, but in our centre, if the viral load was above 3,000 on 2 consecutive occasions, then we would tend to reduce the antiproliferative, and you would monitor the viral load. And I think that's the same in Great Ormond Street as well. And then if you've got symptomatic disease, so symptomatic disease is CMV syndrome, which is where you've got viremia with features such as malaise, fever, neutropenia, leukopenia, thrombocytopenia, or if you've got tissue invasive disease, which is specific infection like colitis, retinitis, nephropathy, then you would stop your antiproliferative and you would commence either IV ganciclovir or oral valganciclovir. IV ganciclovir would be used more specifically for tissue invasive disease, where you might have colitis that might affect your ability to absorb oral valganciclovir. There's currently limited evidence to suggest any benefit from CMV IVIG. So unfortunately, ganciclovir resistance does exist. It's relatively rare at the moment, but I think it is increasing over time. And about 80% is due to variants in this gene UL97, which is present in the CMV virus. There are various different treatment options available if you've got ganciclovir resistance. So maribavir is an antiviral, but there's also increasing resistance to that's emerging. And then there's drugs like foscarnet and cidofovir, which are unfortunately highly nephrotoxic, so need to be adjusted for your renal function. And cidofovir can cause your tacrolimus levels to go a bit haywire as well, so you need to be mindful of that. And the reason why this is important is because chronic CMV viremia is associated with increased risk of rejection and graft loss in the long term. So moving on to EBV. So EBV is also a herpes virus, and we know that immunosuppression affects your cytotoxic T cells and their ability to search for EBV in the body. And if EBV is allowed to replicate, then you get B cell transformation, and that can be a potential kind of pro-oncogenic process that can then lead to PTLD. We know that ganciclovir and acyclovir can inhibit EBV replication in vitro, but that's not really been demonstrated in vivo models. The World Health Organization has a specific kind of lab-based criteria, international standards for the EBV DNA assay, so that hopefully all labs are working off the same hymn sheet so that we get similar results between labs. Although, just from my experience, knowing we have patients up in Aberdeen that we look after, and between Aberdeen and Glasgow, we get wildly different EBV viral loads. And that's being looked into at the moment, but it's a bit worrying. In terms of management, so there are American Society of Transplantation guidelines on this, and also there's BTS guidelines, but more specifically for the management of PTLD. The suggestion is to reduce your immunosuppression. The guidelines themselves don't specifically mention viral loads, but we tend to kind of half your immunosuppression if the viral load's above 4,500 on 2 consecutive occasions, or if the viral load rises above 9,000, then you would stop your anti-proliferative. And you may consider preemptive rituximab if the patient's at particularly high risk of PTLD, so patients that have not been exposed to EBV prior to transplant, patients that have primary EBV infection, patients that have concurrent CMV infection, patients that have received ATG, for example, and also very young patients, so patients younger than 12 months of age particularly. And we know that PTLD risk is increased in children and young people, and PTLD in the first year post-transplant is typically EBV driven, although after 1 year post-transplant, about 1/3 of cases are not actually related to EBV, so we just need to be mindful of that. And this is just demonstrating, so a study that was published in Nature this year. There's been, over many years, lots of researchers have been looking at an EBV vaccine just because of the significant morbidity and mortality that's associated with EBV infection. A multi-epitope vaccine has been trialed in mice with encouraging results. I don't think that vaccine has yet been trialed in humans, but last year they started phase 1 trials of another multi-epitope vaccine in humans as well. So I guess watch this space, but I think we've been saying that for about 20 years now for EBV vaccines. So and then the last of the kind of big 3 viruses that we monitor carefully post-transplant, so BK virus. So BK virus is a polyoma virus. We don't routinely do pre-transplant screening for BK virus because the antibodies are not clearly protective. And there are American Society of Transplantation guidelines for monitoring BK viremia. So the suggestion is that we should monitor monthly for the first 9 months post-transplant, then 3 monthly until 2 years post-transplant. And for children, they recommend extended screening up to about 5 years. Although in reality, I imagine most of our centres just continue to monitor thereafter when we see our patients in transplant clinic. Blood PCR is the most kind of sensitive test for detecting BK. You can test the urine where you can see these decoy cells. So just at the bottom right-hand side, those are decoy cells, these epithelial cells that look a bit unusual that you see in the urine, but you obviously can't quantify the amount of virus based on that. The suggestion from the guidelines is that you reduce immunosuppression if the viral load rises above 1,000 copies per mil over 3 weeks, and certainly you would reduce immunosuppression if you've got a viral load above 10,000 copies per mil on one single occasion. There should be a stepwise approach to reducing immunosuppression. So often you'd reduce the anti-proliferative by about 50% first. Obviously, if the viral load is very high, you might want to just stop it outright. And you may consider reducing your CNI as well. So aiming for trough levels of 6, for example, with tacrolimus. And lots of studies have looked at other alternative therapies for the management of BK virus. So leflunomide, which is a DMARD medication that can be used for rheumatoid arthritis, cidofovir, obviously an antiviral, and then fluoroquinolones like ciprofloxacin and IVIG as well. But there's currently no evidence to support the use of any of those medications, unfortunately. So briefly, I just thought I would touch upon some other infections that are interesting and important for our population. So bacterial UTI I alluded to. So gram-negative bacteria, particularly E. coli, are seen in about 90% of cases, often in the first few months post-transplant. Risk factors are, female, just due to the underlying kind of anatomical differences that increase the risk of bacterial translocation up to your bladder. Underlying bladder issues, which we obviously have a lot of in pediatric nephrology, and then obviously having plastic in situ after your transplant, particularly kind of your double J stents and suprapubic catheters, urethral catheters. And we know that recurrent UTIs may be a risk factor for acute cellular rejection as well. So trying to minimize the risk of infections is important, and whether you potentially have to start prophylactic antibiotics, that's on an individual basis depending on the patient's risk. But obviously trying to optimize their bladder before transplantation, as we discussed yesterday, is important. So hepatitis C was mentioned yesterday. I thought I would just touch upon it today. So the KDIGO recommendations in 2018 suggested that we should not be putting Hep C positive kidneys into recipients who are Hep C negative. But since then, there's obviously been a lot of research into these direct-acting antiviral medications, so DAA therapies, which are given. They're often a combination of drugs that are given based on the genotype of the Hep C virus, and you tailor the medication based on the genotype. We don't have any pediatric data for this yet. As usual, kind of pediatrics lags behind, and I don't think anyone particularly wants to give a child Hep C. But this does have implications for increasing the donor pool if you can then use Hep C positive organs. So just touching upon varicella, so we know that valganciclovir prophylaxis is protective against varicella whilst it's being used, and it's also protective against herpes simplex virus. If our patients, so ideally we would have vaccinated them and they would be varicella immune, but if they slip through the net prior to transplantation and they are varicella naive, then we would, if they've had exposure, then post-exposure, we would advise that they get oral acyclovir or valacyclovir from days 17 to 14 post-exposure. And if they can't take oral acyclovir, they should get varicella zoster immunoglobulin, and that should be given ideally if they're immunosuppressed within 7 days after exposure. And if they then go on to develop chickenpox or shingles, then you should treat them with acyclovir. And if it's severe, it would be IV acyclovir, and you might consider reducing their anti-proliferative. And after they've had an exposure, you should then check their immunoglobulin levels about 3 months afterwards to see if they have then become immune. And there's guidance from the UK HSA that nicely kind of summarizes all of this, and that kind of covers your immunosuppressed individuals, so nephrotic syndrome patients, for example, as well. And then lastly, just touching upon fungal infections. So relatively uncommon, but if you do see them, then Candida esophagitis and cystitis tends to be the most common manifestations. You can see the picture at the top right is obviously a very nasty case of Candida esophagitis. And then second most common tends to be aspergillosis infection. So the CT on the right just shows the lung involvement with aspergillosis, and tends to be kind of median onset of 3 years. Things that increase your risk of fungal infection would obviously be if you're on prolonged antibiotic treatment for whatever reason, and if you're getting high-dose steroids, which, ideally, now that we've got a steroids minimization protocol in the UK, tries to reduce the risk of that, but there are obviously certain patients that do need steroids for longer. And in terms of treatment, the current advice is for fluconazole for invasive candidiasis, but you need to be aware of the effect that can have on tacrolimus levels, increasing those. And amphotericin is used for severe candidiasis and aspergillus infection. So just to summarize, there are many different pathogens, and I've only touched upon some of them, the more common ones, but there's much rarer ones as well. Our patient population is at risk of developing concurrent infections. If they have EBV, for example, you're at increased risk of developing CMV, viremia, and then the risk of developing acute rejection and graft loss is much higher in these patients as well. We need to appreciate the individual risk factors for our patients and screen our patients appropriately, and then act early and monitor closely as well. So thank you very much.
Well, thank you for that. And questions?
Thanks, Doug. Really fantastic overview, and I realized it wasn't a grateful talk to give you, but you've done an amazing job. My question is, just looking at some data actually and some numbers, and very shocking for me to see the percentage of patient that gets hospitalized. Do you think that we are overdoing with their immunosuppression? I know we've done harmonization protocol recently and all that, but do you think that we are over immunosuppressing them from the beginning?
I mean, it's such a balance, isn't it? And I think we're obviously very reluctant to reduce immunosuppression due to the risk of rejection, and finding that balance is really, really hard. And pediatric data that we have is so limited as well in terms of what appropriate immunosuppression is. And I know, certainly I did a fellowship year in Toronto, and we aimed for much higher levels, trough tacrolimus levels post-transplant, and they continued steroids for their patients, and they had their data didn't particularly show that their patients were at any increased risk of infection at that time. I don't have that data in front of me, but I remember them talking about that. So yeah.
Thanks, Doug. That's an excellent summary and overview of infections. So my question is about steroids and when we reduce immunosuppression. Quite often when we are dealing with either PK or say even EBV or even say a chicken pox, we do reduce and stop the antiproliferative agent. But at the back of our mind, we're always worried about rejection happening, especially kind of for the first year of transplant. And we do treat them with, say, some amount of prednisolone. I often wonder whether it's actually doing any good to the patient or is it just treating ourselves. So what do you think should we be having? I think this practice is crept across all the 5 centers. I've worked in the UK. So, but it's not in any guideline. So should we kind of formalize this, or is there any evidence to this? What's your view?
Yeah, I didn't come across any evidence suggesting that when you reduce the anti-proliferative, you should then replace with low dose steroids, and that doesn't seem to be a suggestion in like the BTS guidelines or the AST guidelines. But I think again it's individual risk, and if you've got a patient that's got donor specific antibodies, then you might treat them differently to someone who doesn't have DSAs. And if this is their second episode of having CMV viremia, you might treat them differently if it's their kind of primary episode of CMV viremia. So It would be nice to formalize it between the centres, certainly in the UK, yeah, I think you would need trials of long-term data to suggest that low-dose steroids as a replacement for anti-proliferatives are actually doing anything, if anything.